park at the Tesla place.
Oh, that's right. You got cheap.
And, well, I was parking inside the little box there, and some guy from the thing sort of came over. So now I'm parking out right next to the street, outside the thing. Last time I went, so, and I put a thing on my
Vacations?
Yeah. I was just going to ask.
Hey, there he is.
Did that ever get resolved?
I think it did, because I haven't heard anything from
Okay.
so.
Okay.
Yeah,
I was
so
going to stop by
yeah,
that box.
okay.
Make sure it happened. Okay, thank you.
No raisins here for mine.
Two minutes to 8.
6:59 according to this.
It's only an hour.
I mean, 7.
We're done.
We got a minute.
The word of the day is update. Drew, if you're down in Arizona listening, so far so good. You can text me, tell me if we're online okay. Raffi just told me phonetically how to pronounce his last name, or I would have screwed it up. Tachdjian is our speaker. He came up here from Southern California to get away from the rain. At least torrential rain. Here it just drizzles. Yeah. I mean, it's really unbelievable how much rain you guys are getting down there. So I asked him to do an update on hereditary angioedema, and particularly to address issues like C1 esterase normal, and if there's anything new to help us with that perplexing diagnosis, and new therapies, and just review the entire topic with us. So thanks very much for coming. Again, the word of the day is update. Okay, good.
Thank you. You guys use the first term of every presentation for word of the day?
Oh, that's if people want to get CME credit.
Ah, gotcha.
Code word. The code word.
Well, thank you guys. Thank you, Dr. Allman, Emily, for the invitation. I figured I'd just go through kind of a bird's eye view of hereditary angioedema. Start with angioedema, really, to kind of hone in on the condition and differentiate it from other types of edema. Disclosures are printed there. Learning objectives. So I want to really hone in on the different types of angioedema, and then zero in on the medical burden of hereditary angioedema, which is an area of interest for me. Emphasize the importance and consequence of diagnosing it, the workup, treatment, what's coming up next in the pipeline, and then compare therapeutic options during acute attacks, and you'll see why that's important, and then design strategies for managing the different types of hereditary angioedema. And so we'll do a quick sample case presentation. I do this for residents more so than fellows, and intentionally I try to throw the audience off by kind of profiling in an incorrect way. And so we'll start with a 42-year-old African-American female who wakes up with angioedema presenting to the ED. Her face is swollen. And it's the fourth such episode in the past 3 months. So right away when someone comes to the emergency room, because when you want to teach the ER docs who are going to potentially refer to you, the HAE patients or the AAE patients or whatever angioedema patients, it's good to start kind of thinking their way so that you understand why they're misdiagnosing and misappropriating the patient. When you see someone recurrently having neck or above swelling, you can attribute it all to drug-induced angioedema, which is a bigger pot, right, to think number-wise than hereditary, which is pretty rare. And so, but when you're getting a repeat number of cases, 4th episode in 3 months, the symptoms resolve without any medication, she denies any associated urticaria, which is one of the first questions you should ask. Is there an itching component, or is there a HAE component to your angioedema? Does not recall any triggers. And so we then delve into the past medical history, GERD, hypertension, no atopy. Hey, a bit of a pink flag there that this is not likely an allergic angioedema. Medications, lisinopril. Aha, I learned in med school that ACE inhibitors, well, when I learned it, it was just a cough, right? Now we know that it actually produces the edema that gives you the cough. She's been taking that daily for the past 6 months. Well, we know that ACE inhibitors, and to a smaller extent, ARBs, can give you angioedema decades later. All right? And sometimes even if you remove that agent, you can still have recurrent angioedema. She's a middle manager, office-based, no funny stuff, review system, unremarkable.
You already said 2 things that I want to question you on.
Sure.
Were you saying that drug-induced is more likely to cause it from the neck up than hereditary angioedema?
Correct. Or I should say this. Drug-induced almost never hits you below the neck. Right. So that's kind of a hint. And so if an ER doc or someone in an urgent setting is thinking that, that's fine. But how you get them outside their comfort zone is, if you're getting someone who's getting edema in the left hand, not just in the lip, start thinking outside your box. That's how I changed teaching and learning, basically.
And the other one is, do you actually think ARBs cause angioedema, or it's just coincidental that people prone to angioedema are on that drug? Because mechanistically, you wouldn't think it would do the same thing as ACE inhibitors.
Correct, but in literature reviews, they've been shown to be risk factors. Not as great as ACE inhibitors.
Great.
And you see that a lot. So the other question that comes up then is it the batch that were switched off of ACE inhibitors that went to ARBs that are still having the ACE-based angioedema? That part, I will tell you, I'm not familiar with and can't answer that accurately. Okay. Skin's clear, there's swelling of the face and tongue, upper airways open, good breath sounds, and so on, all the way down. So then you'll draw labs. And the one thing that I ask of, again, I poo-poo the ER docs. Any ER docs in here? No? In fact, I ran around the University of Mississippi system, and it was a room of 150 emergency and affiliated doctors. And I'm thinking, and I lived 1 year in Birmingham, so that's the only experience I had in the Deep South. So I said, the word on the street is y'all suck, right? I'm like, what? I said, but I have to defend you to the patients because they think they're coming to you each time and you're blasting them with allergy meds. After the second or third time, then I have to blame you. But for the first one, when you're triaging things, it's fine to start with what the most probable cause is. And so all I ask of shift-based employees is draw a C4. Because that will come back within your shift. And I'll be all right if you say, hey, I got this patient at 6 p.m. and I check out at 7. I didn't want to have a square box, kind of like in PEDS residency, right? Because I signed up for shift work. So a complement level is always helpful for angioedema. So what is the true definition of angioedema? It's swelling of the mucosa and or submucosa, or the subcutaneous tissue of the skin. And sites of angioedema, when you look at the review in the literature, 94% of patients get head and neck swelling. That can complicate with respiratory tract involvement. 82% of patients can be managed medically. Almost a fifth of the patients will require intubation at some point with recurrent angioedema. And the edema can involve really any part of the body. So I think it's silly when some of the presentations go into, extremity versus abdominal and so on. So it's time to think really what's going on mechanistically to affect the edema. And then on the differential, just categorically, big chunks of categories. Heidi, come on in. I just guess names. That's my specialty. So we have drug-induced angioedema, which would probably be the biggest one that people are going to look out for. Hereditary and acquired are quite rare. Idiopathic, as you know, that's our trash can term, and then allergic or pseudo-allergic angioedema. So let's quickly differentiate between what's allergic and what's non-allergic or potentially hereditary. So the one on the right is my patient. It's actually potentially the youngest patient treated acutely for HAE in the US. So on the left, let's pick away the attributes here. So this kid's got swelling of the lips, and we see big chunky hives, correct? This could even be some other, rule out Kawasaki and whatever else. But if you're going to see a kid like this and tell me hereditary versus non-hereditary, you see this kid here, there's absolutely no redness. The child's not complaining of pruritus. All right. In this case, she has swelling of the upper lip, a little bit of edema in the rest of the face. This kid, I will tell you, with the parent's permission, recurrent abdominal pain. And then when she stubs her feet in the middle of the night, she will go up to the parent's bed and say, I'm going to get an owie. So she knows that she has something wrong with her, swelling and so on, but the history will tell you that there's no pruritus and there's no urticaria associated with the edema. So here she is. Mom got basically used to putting big shades on her so that Department of Child Protective Services won't call her in the middle of the supermarket. And then over here, so we've fully delved into hereditary angioedema at this point, you can see this erythema marginatum, all right? Which I teach parents not to use the term rash. Because once you say rash, what's that new doctor in the new city going to think? Aha, urticaria, thank you for simplifying it for me. Antihistamines, steroids, epinephrine, or whatever. And then here, I don't know if you can tell from where you're sitting, there's a bit of swelling. And again, this is subcutaneous, it's not some sort of ankylosing spondylitis, or don't go anywhere else with this. Some swelling in the middle of the back. And I put that there on purpose instead of other simple edema pictures to show you that it can happen anywhere, the swelling. And one of the big things, I'll go back to right here, one of the big no-nos to do during an exam is to open the patient's mouth and put a tongue depressor, because you can just domino affect all the capillaries and really progress that swelling and put them in real risk. So let's look at the history of hereditary angioedema, first described in the 1800s. The mode of inheritance was identified 100 years ago. Biochemical basis to show that C1 esterase inhibitor activity is at stake was defined in the 60s. The gene was identified and cloned in 86. And just recently, this is what used to be called a medieval disease with medieval treatment, and you'll see the treatment in a second. So this is pretty recent to show that bradykinin is implicated as the mediator for this inflammation, for the attacks. What triggers an attack? And by the way, I never even asked, do we have all allergists in here, pretty much? Anyone non-allergy related?
Yeah, farmers there.
Yeah, sure.
But no other discipline, I don't think.
Okay. So, and who here has HAE experience? Patients or seen them? Yeah, good. Triggers. Oftentimes, I'll say, what are your triggers? And the other big question for managing the patient would be, what kind of activities do you like to do? And you'll see that some of these will self-restrict. They don't like to travel because they don't want to be too far from home base. So triggers, any kind of inflammation can be a trigger, obviously. Infection's a big one. Dental work's a huge one. One that we don't take into account is barometric change, so flight on the descent. Once that pilot says we're coming down from 10,000 feet. Pregnancy, hormonal input, and drugs. Early signs of an attack. So prodromes are big in this condition as of the past 2 to 3 years. To look at when can you identify that prodrome that's going to come on. And it's anything from having some abdominal symptoms to that erythema that pops up. I have a patient that, since putting her on prophylactic therapy, no longer has her rash, which I told her a million times, don't use the term rash, but she's like, my chest rash is gone. So that erythema marginatum, that neurovascular kind of insufficiency look or modeling is gone. numbness or tingling. So it's not unusual to hear a patient say, my left elbow starts tingling, and then I know I'm going to have my abdominal or right leg swelling, whatever the flavor might be for that patient. Fatigue. So patients will say, I'll feel like I'm just hitting a flu-like symptom at that point, just run down, and then I know my swelling's going to start. Muscle aches, and then obviously dysphonia if it's hitting the laryngeal area. And so if you look at your right half of the field here, allergic angioedema, which is a big one, usually associated with hives. The interesting other thing is the swelling in allergic angioedema and the urticaria that come with it will come on and subside usually in 24 hours. That histamine cycle is circadian in a way. And obviously, obviously the condition is responsive to antihistamines and or corticosteroids that you may use. To the left, you can see the bradykinin-mediated angioedema has no hives. The attacks may last up to 5 days. So it's a slow ramp up of up to 2 days usually, and a slow ramp down of up to 3 days. Unresponsive to the treatments that we use for allergic angioedema, and then onset can be pretty early in childhood. If you look at an up-to-date review, 40% of the patients will have been told or will tell you that their first attack occurred under the age of 5. 40%. And having done pediatrics, that was not on my radar. So if you hear that, I've been having swelling since I was 7 or 3, or I've been told scrotal swelling at 1, then it's time to think non-allergic angioedema. And time-wise, we got an hour?
We got an hour.
Okay.
You're fine.
So quickly, I've got a 3-generation, all-male angioedema family. The dad, the grandpa, in a way, retired ophthalmologist, who, when his mom was still alive, had his son, just a colicky kid. All right? Every couple of weeks, wouldn't come out of his bedroom, locked up, whatever, doubled over. So they thought, this is our problem child. I think he was like the middle child. Then he has his grandkid. Grandkid gets scrotal swelling. They all freak out. $1 million workup. Great-grandma, who's still alive, tells now grandpa, you had the same thing when you were an infant. And he thinks, oh crap, I passed on something here. So they do the whole workup. So the first-generation ophthalmologist and the third-generation male, since that time, the third-generation one's a little younger than me, have not had any other attacks. The middle guy continues to have, he's on prophylaxis now. Just to tell you that that attack started really in the first year. So to keep an eye out on those types of symptoms. And lastly, there's a family history in the non-allergic angioedema. And as I said, a prodrome. Whereas for allergic angioedema, you should not have a prodrome, right? I think I might get stung by a bee today. I might take some penicillin today. I think I'm going to get an attack today. And so you can see, I'm preaching to the choir here, with allergic angioedema, that the inflammation is IgE mediated usually, histamine releasing, causing you the edema. Here there is absolutely no indication of histamine or IgE. It's all kallikrein axis and bradykinin production. So here is the nicest study that I know of, but then you need a really expensive machine that's going to measure bradykinin at femtomolars. And it's Nussberger, who did this study in the late 90s, looking at 2 patients. The normal range for bradykinin is somewhere around 0.2 to 7.1 femtomolar per cc. And in the first patient, he measured, these are brachial attacks, on the good arm, 9.5, which is already outside the range of normal. The second patient, 16 femtomolars. So these guys have abnormal bradykinin circulating, but you can see that with a simple blood draw on the affected side, there's local production that's a good 2 to 3-fold increase, and even more for the first patient, of bradykinin occurring. Kind of nailing it down to bradykinin is the mediator for the edema.
That paper was in '99. We really didn't recognize bradykinin as the mechanism until later.
Exactly,
Like
until
this,
the 2000s.
this sort of got ignored.
Exactly. So looking at the overview for HAE, rare autosomal dominant disease. Implications, well, time to look above and below generations to pick up the rest of the family. The mutations in the C1 esterase inhibitor gene, and it's characterized by intermittent attacks of non-pitting, non-urticarial edema in the absence of hives. Prevalence, to me, really doesn't matter. If you go and find, for instance, in upper Minnesota, which you're familiar with, Bemidji, where the Red Lake is, the beginning of the Mississippi River, it's at a rate of about 1 in 130 individuals have the condition, founder effect, and lots of fun, I guess. So not linked to race. You guys are a little delayed.
Yeah, that's good. I got it.
And I'm politically correct. So it's not linked to race. Age of onset, like I said, a lot of these patients will have that first attack early on, but variable age. And women tend to be affected by a higher frequency and severity of the attack, but not the actual condition, right? Because it's autosomal dominant. And that's thought to be due to the hormone difference. So many patients will have that warning sign that I started talking about, the sudden mood change, anxiety. Some patients, caregivers or significant others or kids or parents can actually tell that it's coming on before the patient does. I've seen that. I talked about the tingling sensation, that non-itchy dermatitis. And I want to emphasize again, kind of like ask about hives and itching, but the other question you should say is, how long do your attacks last? And if they're telling you these attacks last 2, 3, 4, 5 days, time to think outside the allergic box. And the frequency, severity, locations can obviously change between patients and within a patient from time to time. So, why do we inaccurately diagnose HAE? First of all, the blood test is not perfect. You guys here do in-house testing, or do you send out to a commercial lab? Commercial lab. Same here.
Well, the university doesn't, but we send them out, don't we? For
In-house for the U.
So do you guys know the difference between all of our labs, including the university labs, except for the Colorado one, and the essentially commercial/university versus chromogenic assays? You guys familiar with that assay? So most of these commercial, and I'm going to guess Seattle's university lab, UCLA certainly, we're looking at ELISA type assays. So for the patient who's saying, why do I have to do this next test that's out of pocket, blah, 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 I'm like, you're looking at cop cars around City Hall. I'm looking at indirect evidence of blow up, basically. All right? Versus looking at actual fractionation of C1, RS, and seeing shrapnel, that something went wrong in City Hall or the bank. All right? So chromogenic assays actually are 100% accurate versus somewhere in the order of about 77 to 95 for the ELISA-based ones. So why is this important? When you get a patient that you're highly suspicious of HAE, you've sent the C4, right, and your C1 inhibitor, functional and quantitative. If you don't get it back as abnormal, the consensus is you should test a year apart, and you should test 3 times, because 2015 might have been a great year for your Merlot or Cabernet. 2016 was a bad one, immunogenetically. So you may pick it up even a year later. You should try 3 times before giving up. And in my book, if you get a normal one after your first one, you still have a high index of suspicion, send it off to National Jewish on your second one and or third one at that point.
How often does a C4 miss it? You're saying function here.
Correct.
How often does a C4?
C4 could, even during an attack, you might miss it with a C4. But usually that's going to be pretty sensitive due to the churning down of C4 from C1 inhibitor not being there.
National Jewish the only place doing chromogenic?
I know that UC San Diego's got a machine or is working on getting a machine at, like,
The HAE Center.
exactly. But National Jewish, at least, I can get you the name of the lab director, and that way when you send a sample, because you got to draw it in your clinic. That's the drag. And they take a cash payment ahead of time to process it. So it's all out of pocket. All right, so it is rare, so that could make it a fault in trying to diagnose it. It mimics a number of other things, right? Especially abdominal ones. Abdominal attacks. You'll see the older generation of patients with their little happy scars. As of 2005, average time between onset of symptoms and diagnosis, over a decade. And only about a half to a little more than half of physicians will use C4 to aid in diagnosis. So that needs to go up. Just throw that complement 4 in there as a screen. So what does it look like? Again, you guys all know this. So here is a patient on a normal day, and here she is all swollen up. What do you worry about here? It's that migration of the attack down to the laryngeal area. And then here's some bowel pictures on a normal day versus a edematous day. The extension of swelling, pretty significant. And as I said, a lot of it can be induced by trauma from even iatrogenic trauma. And so when you're seeing, again, beating this dead horse to the ground, non-pruritic, non-urticarial angioedema that's not responsive to antihistamine, so both your clinical picture and your treatment is not going by the way you think, it could be HAE. That serpiginous rash that you see could be a hint to it. Unexplained abdominal pain, so when I lecture to GI docs, at the end they're like, oh boy, from our $1 million workups, we think we're missing 1 or 2 a year, that we have not simply sent in a C4 test. Now, here's my editorial view of why those docs aren't doing it. But this year or next year, you will see a lot better pickup of this. Because I think I could speak for all of us, even the young ones. When we were in med school, we didn't have treatment. So if I'm a teacher, I'm not going to be excited about teaching you something from A to Q, right? Oh, here's a condition, you swell, blah, blah, blah. You could send a test and see you later. Let's go to the next chapter. Versus whoever's coming out of training right now, who's going to think, oh yeah, first year or second year, the teacher told me, here's the treatment, to whatever the diagnosis was. So there's excitement in going from A to Z for a condition. So that's where we are now with this new influx of trainees. And obviously a family history of HAE is another hint towards diagnosing it. What are the tests? We mentioned C4 as I call it the poor man's test, which is fairly sensitive. So we'll go through type 1. We know that everything's going to be low, right? Essentially because your antigen level is low. For patients, I say, you're driving a car with maybe 3 wheels. You can still drive it. You can drive with 2 wheels. You can Dukes of Hazzard it, all right? But it's not going to be a pretty ride. Every once in a while, you're going to hit some serious damage. Type 2, you've got the normal amount of tires or wheels, but they're square wheels. So it's a choppy ride. Great, it looks like a car, but it doesn't drive like a car. Here's where I think Dr. Altman wanted me to zero in on the normal C1 inhibitor, the type 3. It looks like a car, it's got round wheels, it should drive like a car, but the patient's telling you, I'm hearing clunk, I'm just not feeling this. So, another point to diagnose is when some of the older patients, especially male, will be on androgens. Who amongst you has patients on androgens? And I'll raise my hand too, yeah. Because a lot of that subtype of patient will say, if it ain't broke, don't fix it. All right? But I certainly have not put anyone, I haven't started anyone on androgens. I'm happy to continue them if that's how they feel that they want to treat the condition. Obviously watching for end organ damage and screening them for those. So if a patient's been on androgens and you want to diagnose it, you have to wait 3 weeks from the time they came off of them to get a normal C1. Because what is stanozolol or danazol doing? Bringing your liver to make a little more, just enough C1 inhibitor, which I'll show you the critical point to keep you above the threshold. And for patients that are treated with fresh frozen plasma or C1 inhibitor replacement, once you come off, you should wait about a week to send that lab. Otherwise, you might get a false negative. The handling is important too. Any major hospital, as you know, behind the vending machines, you'll find a lot of test tubes. But I don't mean that kind of handling. Serum should not be left standing for more than 4 hours because you start getting some false positives.
Negative.
False negatives, yes. Thank you. And if labs aren't helpful, and you're still thinking, what in the world is going on with this patient, consider a few of these other conditions. Autoimmune conditions, thyroid disorders. In residency, we actually thought it was an HAE patient and ended up being SVC syndrome. And it was a lot of head and neck swelling. Chylitis granulomatosa, Wilkerson-Rosenthal syndrome, trichinosis, Gleich syndrome could mimic HAE, and then urticarial vasculitis, which we picked one case up this year of that, and it mimicked. Everyone was sending them in the team thinking this is an HAE patient, and a biopsy pretty much proved it not to be. So confounding medications. I actually went in just this past week to make sure that I'm not missing patients or misappropriating them based on meds. And we traditionally think of ACE inhibitors and ARBs, but really it extends out above and beyond the estrogens to, we know NSAIDs and aspirin, but calcium channel blockers, 2 categories. Herbal medications, which you may want to add that to your list when you're intaking a patient for HAE, and then some of the immunosuppressants and psychiatric meds and blood pressure meds. So metoprolol can actually cause angioedema. So now we look at what is that type 3, the daunting HAE with normal C1 inhibitor. Any questions so far? Okay. So this is the one formerly known as type 3, first described in 2000. It really lacks diagnostic criteria. First of all, we don't have a good lab test for it. There's heterogeneity between different patients, within a family even. And you have 2 subtypes. One that helps you send it off to National Jewish. If you find a factor 12 mutation, then you're pretty much set. There are 4 mutations identified to date. And last I checked, there were only 2 patients identified in the US. So it's more of a European lineage families that have this subtype. And then you've got the unknown HAE, a truly unknown normal C1 inhibitor subtype, which has to do with degradation of bradykinin. And I think you asked me about factor 12, yeah. Again, these are going to have everything normal, including your factor 12. So we just don't know what the heck's going on. The assay is going to be a golden test that someone's going to be shining in the field once they identify it.
What about the bradykinin assay? Have they checked it on this syndrome?
Yeah. So some of those patients will still have normal to low bradykinin levels. High bradykinin levels. And I mean, I imagine, and I don't know all the players that are looking into I'll show you the immunology cascade, obviously, like you know, not finding any kind of mutation or defects surrounding that bradykinin production, essentially kallikrein.
But they can have normal bradykinin levels?
They could. Okay. So the last thing is treatment should not be used as a diagnostic aid. And we used to do that a lot. Here, try some product B, some product C. What's the patient going to say? It worked. And that quantification is horrible. All right?
Well, wait a second, but you have almost no other option but to try a diagnostic trial if you think, otherwise you're stuck.
I agree. But
I've had patients who clearly know, they say to me, my attacks are much shorter and much less frequent when I'm, you give them whatever HAE treatment you choose.
Sure. With the replacement therapy, it doesn't make sense, right?
No.
Theoretically. With the blockers, it could. And is there some middle mediator that's coming in and out of the page that's not made it to the immunology textbooks or journals? Potentially.
I'm curious if you've come across any patients with like indolent mastocytosis that just have angioedema. Because I have 3 50, 60-year-old guys, and they happen to be mildly atopic. They itch a bit, and they look just like HAE patients.
Yeah.
Their workup's totally negative, and the key, like you said, is it's short lasting when they get it, and they've done very well with mediator blockers, which with tryptases of 20, obviously, makes sense anyway. I'm just curious.
And they're
if you've ever
in and out
come
of their
across
zone.
that, all they ever had is angioedema. Never had hives.
And no pruritus.
No.
Yeah.
Very strange.
Well, it raises the question I was going to ask you. Why do we see some people with histamine-mediated disease who only get angioedema and don't get hives? And that's the conundrum.
Or mix and match. Sometimes they have both, but 80% of the time it's just...
Well, some say I never, that's the...
Yeah.
People who
Absolutely.
just say
Got
I
tons
only
of
get
those.
angioedema.
We call it idiopathic angioedema. You called it allergic, but we don't find an allergy, so I don't know if that's the correct term for it.
Yeah.
Agreed.
Maybe mast cell mediated.
The other thing is, what is the perception of the sensation? Someone's pain is someone else's, pruritus is someone else's, neuropathy like report. Yeah. Which is why it's a good thing to ask about the quality of the sensation when you get the hives. Is it burning? Is it itching? Is it painful? All right. But here's what's interesting for the normal C1 inhibitor types compared to the ones who actually have a known defect. They'll present later in life, so the mean age is well into their third decade versus 11.7 years of age. They have more prominent involvement of the tongue, uvula, and face, so it's looking a lot more like drug-induced, and who knows, they might have some exogenous input of something going on. They have less frequent abdominal attacks, so only half of them will report abdominal attacks versus the great majority of type 1 and type 2s. We know that we used to call this a female-only condition, type 3, normal C1, but it happens in men too, but it's a lot more in female patients than male. In the literature, it says less intense, but I find the type 3s anecdotally as more intense, Probably because I don't have a name to my condition. This is driving me nuts, and it's worse than it was yesterday. More variable disease activity. They have less bruising and less prodromes versus type 1 and type 2 patients. So, again, could it be histaminic, tryptase mediated? Something's going on that we have not exactly nailed down, partly because our N is small in all the different centers. And then there's obviously low penetrance in this condition. So, pathogenesis of normal C1 inhibitors. So the mediator responsible for swelling has not been definitively identified, but we know that there's excess generation of bradykinin excess generation of bradykinin in the C1 inhibitor deficient or dysfunctional HAEs, and we think that the kinin system is affected in the normal C1 inhibitor subtype, but not conclusively demonstrated. And the molecular defects have not been identified, so that's a good project for a fellow even to take on. But good luck, you'll never finish your program. And then when we look at the target levels for C1 esterase inhibitor, we know that the optimal efficacy level is achieved when you get 50 or more units per kilo of C1 inhibitor replacement, which then increases your plasma level to 0.7 units per ml or greater. And so that's kind of the lower limit of normal to prevent attacks. And that's what some of the replacement therapies are aiming to do, whether it's prophylactic or acute. Because once you dip below that 0.7 level, you're prone to the trigger causing your swelling. And the efficacy of C1 esterase inhibitor therapy is optimal when you maintain that level. Here, we're going into a lot more detail molecularly. So the important sort of salient points are C1 inhibitor is a acute phase protein in circulation, it irreversibly binds and inactivates C1R and C1s, which is all the more reason to test chromogenically to rule in or out at least the first two types. And then there's proteolytic cleavage that can happen when you're taking out C1 inhibitor from C1 churning down C4 and then C2, which is why for your patients you want to give them a heads up and say your risk of autoimmunity can go up. And sometimes you might find a lupus patient coming to you and saying, I'm swelling, swelling, swelling. It can actually be an HAE patient that's having lupus-like symptoms. That's having lupus, essentially. And we know that C1 inhibitor also inhibits fibrinolytic, clotting, and kinin proteases, and it is the most important inhibitor of plasma kallikrein from high molecular weight kininogen and factor 11A and 12A.
With regard to mapping the mutations, is any of that helping at all with regard to the phenotype, clinical phenotype that we see?
Yeah, so in chromosome 11, when you look at, again, it's for type 1 and type 2, there are known mutations that occur. And so that little girl that I showed you, her dad got identified, actually nailed down to HAE or mastocytosis by his wife, who couldn't take him being out of commission right after their honeymoon, and during their honeymoon, I guess, because he was curling away for 3-4 days. And so his same mutation got identified in the, basically at birth from cord blood for the child. And I think I was telling you guys last night. So the child then got picked up by the pediatrician, starts having abdominal attacks, gets referred to a GI doc, who then rules out everything, sends the kid to another allergist, who then says it's food allergies, does a barrage of tests and says no soy, no egg, and whatever else. So for a couple of years, this kid was just walking around being identified as a food allergic, maybe mastocytosis kid, even though the parents were told that you have the same mutation. And so yeah, genetic testing helps, but it's not critical once you've identified the levels. So phenotype-wise, it's good enough with labs, but it helps to have the genetic mutations identified.
Bill, was your question, does it help with type 3? Or does it help in any way to
when
know?
I've seen it presented, like from the European data, it looks like it was all over the map. They got the 300 mutations. And
Correct.
You can't pinpoint, I was just wondering if some people have more angioedema or more GI.
Well, based on their mutation?
Yeah.
Yeah, you would think that the worst mutation is going to give you more severe disease, but that has not panned out to be the case.
Kind of related to that, if you look at the type 2s, and you look at activity, do you see a spectrum from like 20 to 60%?
You could.
It might give you, so there's a little bit of that maybe.
There is, but there's variability within the same family too. Kind of like the case that I told you about, the 3 generations, where it's the same exact mutation, but it's having different penetrances, essentially.
So this is a philosophical question. I've always wondered why human development permits 300 abnormalities in a crucial gene, and all those people survive. They don't all survive. It just seems biologically implausible why we have 300 mutations in one critical gene.
Well, I'll give you this bit here. 2 reports of homozygous deficiency exist, where you think it's probably lethal at that point, and it's not. So you're making, even with that bad gene, you're making a little bit of C1. So you got 1 tire at least, or 2 tires going on. So again, it's in critical times with a trigger or a stressor that you're dipping below that crucial level. And so, yeah, great question, but I can't correlate genetic hits with real life picture.
How often do you see sort of false positives with C4, just given the 4 allele deal? I mean, granted, you're self-selecting who you're checking.
True.
As I've seen a couple of those.
Yeah.
I mean, you just actually send it off, and they only have 1 allele for C4.
False positives?
I mean, so to speak.
Yeah.
In other words, you looks like you'd expect them to have C1, but they don't.
Exactly. At that point, you're looking at autoimmunity,
Right.
immune deficiency. And since you brought that up, actually, C4, we're taught that really below 14 is abnormal. But I've actually had a conversation with an insurance, I call them adjusters, the podiatrist that's in charge of giving the green light for treatment, who told me, oh, as long as it's below 20, that's all we look for, and we're convinced. So to me, once you hit the teens, that's a low C4, even though the range will say in the lab, I believe usually is 14 to 20 or 30 something. So yes, you see that a lot, sometimes peripherally when you weren't even thinking angioedema. All right. Mechanism, well, despite uncontrolled autoactivation, levels are going to be low during an acute attack, which makes C4 a pretty good test to start the game. And then this was kind of more information for your reading if you're interested in heart damage cells and what happens with the whole complement system and factor 12. And then we know that C1 inhibitor is the major player or the general on the field that's controlling various spots of your inflammatory cascade as it relates to angioedema. The main one being kallikrein conversion to high molecular weight kininogen. Kallikrein helping convert high molecular weight kininogen to bradykinin, which then activates your bradykinin 2 receptors. The bradykinin 2 receptors also modulate pain. There's a big component of pain, which oddly enough is what brings in the abdominal swelling patient to seek help. So if you look at a lot of the abdominal swellers, or the patients who have abdominal attacks, they may not look like they're poofing out. So I call it the airbags are going off in their little Mini Cooper. But it's really that when you start talking to kids and parents, you got to just bring it down to HAE for the ground level. So for them, it's the pain rather than the sensation of swelling that's bringing them in. That's driving them crazy.
Just a side question, mentioning, attacks more common in women and so forth and the hormonal thing. Is there actually a reason, in other words, does progesterone make kallikrein work better or something? And does anybody know why that is?
Yeah. It may not.
I'm just curious.
The thought is it may not amplify it as much as, or at all, versus estrogen.
Gotcha.
And that conversation with the OBGYN is a lovely one too, because they start cursing you out, saying, you want me to do what? Switch this patient out to a progesterone, that's not going to work, and blah, blah, blah.
Yeah.
All right, so current therapies, there are 2 categories, and I will fast forward. So here, there's we'll start with the acute ones, because the consensus is whether you have someone on prophylactic or not, you should at least have an acute therapy plan in place, almost like the equivalent of your EpiPen, even if you're avoiding the peanut or putting a kid on Zantac and all kinds of antihistamines to send them off to camp. So there are 3 types. The one that's missing, and I apologize, should be the recombinant C1 inhibitor replacement. So you have 2 types. One is a human, one is a recombinant, and I can send you that slide corrected this afternoon. And then you have ecallantide, which essentially comes in and corrects or inhibits the plasma kallikrein. And then icatibant, which blocks bradykinin receptors. So that's acute. And then on the prophylactic side, you've got the old school danazol and what other variants, but that's the US approved one, anabolic steroid, and then direct replacement with human C1 inhibitor, C1 esterase inhibitor to prevent and or abut attacks and dampen attacks. So anabolic steroids, reason to use them, a lot of people were on them, and I think this was a lot of data from Dr. Frank, who he and his group threw a bunch of compounds at patients, and they saw a signal with anabolic steroids, essentially. And to me, the simplistic mechanism is it's basically wringing out your liver to make a little more C1 esterase inhibitor. It's oral, it's cheap, but a lot of contraindications. C1 esterase inhibitor replacement as a prophylactic. You're basically bringing in new tires, new wheels to your system. Then you get into the acute therapies, so another form of C1 esterase inhibitor, which actually has a shorter life in the preparation, which makes it FDA approved for replacement during attacks rather than replacement prophylactically. Kallikrein inhibitor, bradykinin receptor antagonist, and the recombinant form of C1 inhibitor. And so yes, HAE is treatable. Here's that girl on a healthy day. And in conclusion, there are more than 5 subtypes, and at some point we'll have endotypes, kind of like we're getting in asthma to kind of clean up this disease state for angioedema. But we know that for the 3 types of HAE, you can differentiate them by C4 and C1 esterase inhibitor levels and activity. Acute attacks can be disfiguring. They can warrant unnecessary procedures, and they can be deadly. In Southern Cal, there was a case of a female who had been on anabolic steroids for years, decided I'm not having attacks, the disease might have gone away or quieted down. So she comes off of them, and I forget how many years later, has a really bad laryngeal attack, calls 911, they show up, she's hunched over on her kitchen table, and they see a little napkin with 3 letters, HAE, on it. Take her to the hospital, she's DOA. Autopsy shows 40 pills of the anabolic steroid. So she thought, if I quickly take these, which are a prophylactic therapy, it'll curb the laryngeal attack. Not so.
Does testosterone work? Because a lot of men are on it now. And maybe that'll work and they won't need the expensive drugs.
True.
Nobody's looked at that.
Yeah.
Well, if you go back to Mike Frank's original paper, the success rate was for danazole was phenomenal. It was over 90%. It's actually better. You know, if you read the papers on all the new therapies, they're not actually as good as his original therapy. The only problem is all the side effects. But I still have men and even occasional women. Well, you know, some people you can control on as little as 50 milligrams a day of danazole. It's hard to beat, and it's very cheap. I know some people say that's old school. You shouldn't do that. Nobody should be on it any longer. But
do you know at the normal dose how much does that increase the C1 inhibitor level? You know, just curious.
Yeah, it's going to have variability from patient to patient. Normally, I've seen 100 to 200 a day being used, but obviously, the less you can get by, the bigger.
But I mean, like if their level was X of C1 inhibitor, is it 20% more? Or?
Yeah. That assay is not readily available to measure that 70% threshold, but it'd be a nice study to do.
And back to the so-called type 3, I talking to Mark Riddell down in San Diego. He tells me that they're getting close to some kind of bioassay for that disease, which is what we need. See, we got a lengthy question from Chuck Jackson here. This may be too long to read during the session, but then he wants me to read it. I have a 49-year-old woman who began having angioedema at age 21. In the last 10 years, 4 to 5 episodes a month, predominantly face, lip, eyelids, lasting 4 to 5 days, tongue and uvula involved about once a month. Never life-threatening respiratory obstruction, denies hives and pruritus and abdominal pain. Family history is negative. Response to antihistamine and epinephrine have been equivocal. No history of usual allergy symptoms, no obvious triggers of AE. Interestingly, she has 4+ dermatographism, C1 inhibitor protein and function, and C4 all normal. Resting histamine level normal, tryptase barely over the limit. Currently taking a 3-week course of TID Allegra. Result not yet known. If antihistamine is not effective, consistent with type 3 HAE, would factor 12 genotyping be worth pursuing? I'll partially answer that. I've never had anybody with a factor 12 positive. I stopped sending the test. But what do you think from that lengthy question?
biggest clue there is tryptase slightly above normal. So I would pursue mast cell disease first and bump up that see what the 3 times Allegra they said, 4 times tyrosine a day, see if that kind of blocks it first. And equivocal to me might be enough to say, well, this is sounding like histaminergic edema. So rather than chasing the expensive tests and our tails, I would pursue allergic angioedema first there.
What are other people? It seems to me that it's easy to still call it type 3, but they want to call it now C1 esterase normal. How are you managing these people? How many are you seeing? I'm almost seeing more of that than typical type 1 and type 2. Very frustrating.
Part of it's what people read on the internet, right? Yeah. Trying to fit a square peg into a circle hole. And there's treatment for it versus some of the other kind of floating conditions in the air where you don't have great treatment.
There's another outside question. I have 3, I don't know what this means, out of 5 maybe, 3 HAE with normal values who respond to C1 esterase inhibitor treatment. They are all presenting mainly with abdominal attacks. Firazyr is given dramatic benefit. He has a total of 25 HAE patients. That's from RFA. I agree. I have had people have dramatic response to Firazyr. And I just the opposite of what you had on your slide. I've used treatment as a diagnostic test as to what disease they have.
Here's why I say not to. So I think I told some of you guys I met last night. I kind of still do pediatric pain as well. I used to head up the pain program for peds at UCLA. You can block histamine with acupuncture. All right, you can block the histamine response locally with even dry needling, toothpick needling. So, is that the treatment for histaminergic inflammation? For that moment, while the needle's in, yeah. And so, anytime you're you're putting in a procedure, especially an expensive one like Firazyr, there is a psychological effect in the patient to say, I'm getting treatment. When you look at the trials for HAE, as you do with vehicle, just nasal sprays for allergic rhinitis, there's a huge placebo effect. In HAE, it's gigantic. You're getting that hand on the shoulder, I believe you, right? Oh my gosh. All that inflammation from this category is gone. You get a little bit of hydration. You're being tended to. Your pain is being managed. So that's what's... So I can't remember if Frank's initial studies on androgens included the placebo effect above and beyond.
Yeah, I'm pretty sure. We have to go back. The paper was 40 years old now.
Yeah. So when you're looking at the effect, yes, not just a needling, but a good amount of fluid going into you and so on has to have an effect on its own, even if it was placebo. And it has. It's shown it in the trials. That's why I kind of drift away from attacking it from a therapeutic diagnostic angle first. But I'm with you. Sometimes that's the only leg we have to stand on, and it helps. So, just to wrap it up, remember to screen the family members. This is pretty much stuff that I show medical schools residents. If you want to, feel free to use this slide. It helps for your practice build-up. Emphasize the fact that a lot of education goes into addressing these patients. And so HAE can be diagnosed by pretty much all of these, you know that. It could be effectively treated with everything except the first category, right? Antihistamines, epinephrine, and corticosteroids. Epinephrine I still prescribe just in case a patient wants it, because it could buy you about 10-20% space and time in trying to forcefully open some of the edema. But mechanistically, it's not, or immunologically, it's not doing much. And it certainly doesn't work as well as it would in allergic angioedema. And then HAE is associated with angioedema that's non-pruritic, non-urticarial, and really not responsive to antihistamines. It does have the serpiginous rash, the erythema marginatum. You could have unexplained abdominal pain, and 75% of the time, roughly, family history of HAE. And that holds true. I finished a paper a couple of years ago looking at home infusion data from one of the companies, and it kind of matched this number that the great majority will have a family member or an inheritance pattern. And then, since this is a non-pharma talk, non-sunshine, I can actually plug my charity. We served a kid up here at Seattle Children's who underwent leukemia treatment, is now back on the football field at 13 or 14 years of age. That's my little, that's my baby, the Children's Music Fund. So we bring music therapy to kids in and out of the hospital. So any kid or young adult with a life-threatening illness, we get them a musical instrument and, more importantly, a music therapist to sit with them to beat down the pain, anxiety, and fear that are associated with starting chemo or other procedures. So if you have a kid in any of your wards who could benefit from that, let us know, and we set them up with a music therapist. And I'll give you a quick little blurb for a little extra credit. This kid did not have the knuckles all red, hint, hint, but had weakness in her muscles. We did a pulmonary function test, FVC, FEV1, 40%. Looks like a peach. You know the diagnosis? Juvenile?
Dermatomyositis.
Yes, dermatomyositis. Minus the dermato part, really, for her. But CK aldolase are messed up. This kid went in for bone marrow transplant, had funky infections, and his pediatrician did a peripheral smear showing that the neutrophils were bulging. Shediak Higashi. And then these two clowns, he was my fellow a year below me, and he was our resident. They're bringing in an instrument. So Mike went on, he's in San Diego now, went on to do a lot of the work with Wesley Burks on food allergy at Acute. So, thank you.
Thank you. Last time I was in LA,